Hello, everyone. Thank you so much for attending this introduction to TMS webinar with Saad Shakir, MD. We are delighted to have such a renowned expert in the field of TMS presenting on this topic. Wanted to share a bit about Dr. Shakir's bio. So formally Saad A. Shakir, MD, DLFAPA, FCTMSS, and I'll explain what all of those things mean. He is a distinguished life fellow of the American Psychiatric Association and also an honorary fellow of the Clinical TMS Society. Dr. Shakir is a board certified psychiatrist with many years of extensive experience, having been trained in medicine, neurology, and psychiatry. A pioneer in transcranial magnetic stimulation, which we call TMS. He founded Silicon Valley TMS in 2010 and has since helped more than 7,000 patients treated under his supervision to benefit from this innovative treatment. Now the medical director at Neurovana TMS in Orange, California, Dr. Shakir brings his expertise in neurobehavioral medicine, neuromodulation, and integrated mental health care to support patients with treatment-resistant depression and many other neuropsychiatric conditions. Dr. Shakir has held leadership roles, including president of the California TMS Society and adjunct clinical faculty at Stanford University's School of Medicine. He was a co-founder of the now International Clinical TMS Society, has contributed to research on TMS for OCD, published widely, and presented both nationally and internationally. Among many other awards, his honors include Distinguished Life Fellow of the American Psychiatric Association, Honorary Fellowship of the Clinical TMS Society, and the Life Achievement Award from the Iraqi Medical Science Association. Dr. Shakir, we are so excited to have you present.
Thank you, Jordan. This is great. It's a great pleasure to be with you all, and really to be working with Neurovana, a group of dedicated professionals who are interested in TMS. Jordan, you probably want to take this slide on, as you are the co-founder of Neurovana.
Sounds great. A little bit about Neurovana. We are a dedicated transcranial magnetic stimulation, TMS, clinic founded by mental health providers who believe in targeted, non-invasive, and science-backed treatment. Neurovana of Orange County provides cutting-edge care for patients who haven't found relief with medications or talk therapy alone. We work in collaboration with local mental health and medical providers to support patients on their journey to wellness.
Thank you. The next slide is the introduction of the main players. The next two slides. Jordan, do you want to introduce?
Absolutely. And in addition to Dr. Shakir, we have some technicians, certified TMS technicians, Kate Austin and Auden Brown, as well as a lifestyle and wellness coach, Kayla Hawking. Our chief medical director is Dr. Emery Jamerson. I am a licensed clinical psychologist and the CEO of Neurovana. Also joining us today, we have Dr. Lauren Ashley Shapiro, a licensed clinical psychologist and president of Neurovana, Brad Holtzman, our chief financial officer, and Danielle Kristen, our client coordinator, provider relations specialist, and office manager. Thanks everybody for being here today. And here's our photo for all of you who want to know what the team looks like.
That was taken by real surprise. We could have made more of an effort to look photogenic here, but it gives you an idea on who's who. So in the middle three are the three founders of Neurovana. So Jordan, Brad, and Lauren. And then Danielle, who is the coordinator, is standing on the right, and me on the left. And then we have the two technicians in the left front, Auden and Kate. And then we have Kayla, who is the health coach that works with us. Thank you. I think we can proceed now with the next slide.
All right.
I don't know how familiar people are with TMS, but I would like to start with an outline of what TMS is approved for. So it's FDA cleared for major depression, which has really been the bulk of research since and our clinical experience. I'd say about 80% of the patients I've treated, of the 7,000 you mentioned, have had a major depression with or without anxiety. We've had geriatric depression. Adolescent depression was approved recently, actually, in the past year, which is really nice, from 15 to 18. OCD was approved about 5 years ago, and about 3-4 years ago, smoking cessation was approved. So that's tier 1. Tier 2, there's strong evidence that TMS may help, but it's not FDA cleared. And that includes refractory generalized anxiety, panic social anxiety, and adolescent adult ADHD. The third tier on the right side of the slide shows a lot of anecdotal experience and clinical experience, which I'm happy in the Q&A period to take questions about if you wish. But to give you an idea of some of those conditions: bipolar depression, chronic pain, neurological disorders, particularly MCI, mild cognitive impairment, pre-dementia. There's good interest in that. Also PTSD, fibromyalgia, postpartum depression, and many other conditions we can address during the Q&A. Next slide. Great. So this gives you an idea about the bulk of the research with and clinical experience with major depression. Now, I'm sure most of the attendees are familiar with how significant depression is, not just in the US, but around the world. It's estimated to have about 300 million people internationally implicated with depression, and we know many of them are not getting any treatment, let alone evidence-based treatment. So that constitutes about 4% of the world population. Depression affects not just the brain, but has systemic impact. It's associated with depression, with obesity, cognitive decline, hypertension, cardiovascular disease, GI issues, chronic pain. We'll get into that a little bit more detail in a future slide. There are some physiological effects on the body systems, including the hypothalamic pituitary adrenal axis, HPA, which is the main axis for hormonal regulation and is associated with metabolic disorders, autonomic nervous system, endocrine and hormonal imbalance. The area that we really are very interested in is the prefrontal cortex, the anterior cingulate, the amygdala, and the hippocampus. I think the next slide will lead us there, if we can go to the next slide. So the next slide shows you the areas in the prefrontal cortex, anterior cingulate. So the prefrontal cortex involved in executive function, inhibitory control, and that's really the main target of the TMS treatment that is approved for depression. And the brain is highly connected and wired, so that it affects the anterior cingulate, which is implicated in emotional regulation and pain modulation. Hippocampus, which is the area you see that looks like a horseshoe. The hippocampus is the center for memory and emotional regulation. And there is research that there is atrophy in that area of the brain with both depression as well as PTSD sometimes, some of the research, as well as dementia issues and cognitive decline. The amygdala is a very important part in psychiatry, and that is the area of persistent regulation of mood. I call it the emotional thermostat of the brain, and it's associated with imbalance in the amygdala with negative moods, rumination, and heightened sensitivity to stress. Next slide. So we are really delighted that now we can see the brain with metabolic scans. So this is a picture of a PET scan. So you see a big difference between the left side and the right side. The left side is a depressed brain. This is obviously very severe depression. It's basically shut down with no activity. The right side of the brain is a normal, healthy, functioning individual. and the highlighted area indicate healthy brain function. So now we can see depression, not just experience it clinically. This is a tool that's used widely in research and not yet mainstream medicine, but for this presentation, I wanted to show you so that you're well aware that there are anatomical and physiological changes. Next slide. So the next slide leads us to more microscopic issues. All of us are familiar with monoamine oxidase, and that's a lot of the bulk of the research on the antidepressants, serotonin, dopamine, norepinephrine. Some of us may be aware of the BDNF, which is brain-derived neurotrophic factor. I call it the fertilizer for the brain. That's associated with neurogenesis in the hippocampus. So remember that term, neurogenesis. Those of us who were trained in the 70s and 80s, we used to think that the brain did not regenerate. Wrong. There is regeneration in the brain if we apply the right formula, whether it's electrochemical, magnetic, or medications, if they hit the right target. And on the right side, you see neuronal connections. There's also interest in neurotransmitter transporters, norepinephrine, dopamine especially, and serotonin transporters. There's now a lot of research on inflammatory markers and affecting the glial activation, inflammatory cytokines, and that's a big area that's associated with autoimmune issues and associated systemic illness, highly correlated with depression. The bottom bullet is physiological correlates, which means a connection with cardiovascular, autonomic, and endocrine function. Next slide. So this gives you a more description of the areas I touched on. So the systemic illness of depression affects a cascade of health issues, and we all know there is more evidence of premature death, cardiovascular system, increased risk of heart disease, hypertension, strokes. There is also evidence of impact on the highly correlated with digestive system. As a matter of fact, those of you who are interested in GI know there's a popular term now called enteric nervous system, which is the wiring of the gastrointestinal tract. And you see irritable bowel syndrome, abdominal pain. So those are areas implicated in the enteric nervous system, which is highly connected with the central nervous system. Then you see metabolic issues. We know the epidemic of obesity, metabolic disorders, the epidemic of adult onset diabetes, or what's called diabetes type 2. There's also implication of the endocrine system, including HPA dysfunction, the hypothalamus pituitary adrenal axis, hormonal imbalance. Thyroid is a very important aspect in depression. There's a high correlation with hypothyroidism in depression and hyperthyroidism in anxiety. So in a good workup for initial patients, we need to make sure that we check those things also. Neurology and psychiatry are very first cousins. So there's impact on cognitive decline. A lot of the elderly patients we see with depression present with what used to be called pseudodementia, which is cognitive decline. But as we understand it more, we think it's an element of depression. And that's the good news here. I actually am trained in neurology and psychiatry, so I used to get patients who are referred for dementia, and we investigate and we find out that they have actually, in quote, pseudodementia. So I come out smiling and saying we have good prognosis dementia, if you will, and we can treat it effectively because the prognosis is much better with mood treatment at this point than Alzheimer's treatment, which is emerging evidence now, but it's still lagging behind for sure. Additional systems are implicated. We know high correlation with migraine, chronic fatigue, sleep disturbances. Sleep is a very essential part of the formula here. Next slide. So I mentioned BDNF. So this slide on the right shows you a trial of 48 individuals with depression in blue, and the controls were 62 in the orange. As you can see that there is diminished BDNF in patients with depression. And that impacts neurogenesis, reduced neural health, and there's inflammatory risk. So this is the evidence of the BDNF issue that we refer to. Next slide. So this really gets us into the mechanics of TMS. So first, let's talk about, as you know, we take a very holistic approach. So on the left side of the slide is everything we do that we encourage patients. For example, we all know exercise helps BDNF, and research shows that it helps mood regulation improvement. A lot of people use it for mild depression treatment. Mental stimulation, always a good thing, especially in elderly patients. We encourage them to read, do Sudoku, crossword puzzles, learn a new language, but that's really very helpful in BDNF generation. Sleep is always crucial. I mean, there are some people say, oh, I don't need more than 3-4 hours. Wrong. Check their cognitive functioning, because sleep is really important for cognition. Sun exposure, we are now beginning of the fall, and we all know when in LA area, we don't really experience it much, but many parts of the country, seasonal depression is a big issue. And we know that light exposure, particularly natural sunlight, there are therapeutic lamps also that are available. Intermittent fasting has really gotten some attention lately, but as I said, this is not a comprehensive presentation on it. I just want to list it here as helpful. So is diet rich in flavonoids, fruits, vegetable. I particularly like the dark chocolates, Jordan. I'm glad you included that here. So dark chocolates, coffee, olive oil, coffee with moderation for sure. I wouldn't do it excessively because it's highly associated with increased anxiety also, caffeineism. Olive oil, omega-3, etc. The real wonderful thing I want to bring to your attention is what we know about the TMS now. So you see on the right side of the slide, TMS may help increase BDNF in affected areas in a very focused, localized way, as you'll be seeing in the rest of the presentation. Next slide. So this gives you a little timeline on the history of treatments in neuropsychiatry. Those of us who remember the 20th century, beginning of the 20th century, there was only available insulin shock, lobotomy was used until ECT became available, shock therapy, what's known as electrocortical therapy or electroshock therapy. That became available in the 1940s and 50s. And at that time, it was used without anesthesia. It's still available now in some centers. And now it's used with anesthesia and one-sided, both-sided area of the brain. But let me point out, this is very different from TMS. ECT is an invasive treatment, which involves anesthesia, sometimes hospitalization, induction of a seizure. TMS doesn't, so very big difference between the two. Then we have in the mid-50s, tricyclics became available, amitriptyline, imipramine, and others. Then there was a revolution in pharmacology when Prozac hit the market in 1988 with SSRIs, selective serotonin inhibitors. Then 1990s onwards, SNRIs, atypical antidepressants like bupropion, Trintellix, and others have come on the market also. Then there's augmentation, became very popular at the beginning of the 20th century because we're really hitting blanks here with treatment, augmentation strategy, including using atypical antipsychotics with all the risks associated. And of course, in the psychological front, we have a big advancement in evidence-based psychotherapy, including CBT, DBT, EMDR, etc. So there's a lot of progression in the psychological field of treatment. Modern treatments is TMS, VNS, which is vagal nerve stimulation. That involves surgery. So that's been approved, but really very rarely is pursued because it's one, not covered by insurance, and it's very expensive treatment. And it's invasive because it involves surgery. And then there is pharmacogenomics, which is personalized medicine. Some of you are familiar, there are some companies that take a swab, saliva, and tell you which medications are compatible with which individual. And there's a genetic evidence with that. And then we have on the right side, emerging and future treatments. Spravato. So ketamine has been around for many years, but not FDA approved. The S-ketamine, which is Spravato, got FDA approval and it's been around for at least a decade. And then TMS has also evolved into intermittent theta burst, which is shorter, more intense treatments than traditional TMS. To shorten the period of the treatment, Stanford research came up with accelerated TMS, which we can discuss in the Q&A period, which is basically 50 sessions in 5 days, so very intensive. And it's not yet FDA cleared yet, but very promising within a year or two that may be available and covered by insurance. It's available now. We do it also at Neurovana, but it's most of the time it's not covered by insurance at this point. And then there's a big field of psychedelic therapy, including psilocybin and MDMA and magic mushrooms, etc. But the key insights of this slide is that TMS represents a shift from systemic approaches to targeted neuronal focusing on specific areas of the brain. Treatment has evolved from pharmaceutical to multimodal approach. Next slide. So limitation of antidepressants. With all the excitement about the Prozac and onwards, there are a lot of limitation, even though the SSRIs and SNRIs are more selective than the tricyclics, but there's still what I call a shotgun approach, because you're really not targeting an area specifically. It hits many other areas of the body, as you can see on the right side, and is associated with high discontinuation rates, systemic side effects, which you're all familiar with, GI side effects, blurred vision, cognitive side effects, drowsiness, insomnia, agitation, sexual dysfunction, etc. So it's not quite the magical solution. Next slide. Additional limitation of antidepressants, what's called tachyphylaxis, which means with time, those of you who have been around for a while, remember there was a term in the 1990s called Prozac poop outs. And those were those who have initially reacted very positively to Prozac. It was also almost like a magical drug. And then it fades after a while. And you see that here, diminished return with time. And delayed onset of action, tachyphylaxis, which is rapid reduction in effectiveness. And oftentimes you need to do what's called polypharmacy, which means poly side effects also. The next couple of slides, next slide. So this is, some of you may be familiar with the STAR-D trial, which was done by the NIMH. And it's probably the largest study in the world on depression. This is a good reference. I'm not going to dwell on it too much. In 2006, the leader of the study was Jonathan Rush from Texas, published in 2006. What they did, the next slide will actually, could we go next slide and then go back? Jordan, next slide. Yeah. So this shows you first level. So basically, everybody in the trial, it was not sponsored by any drug companies. Everybody wanted to try SSRI first. So at that time, Lexapro was not yet available, but the parent drug of Lexapro, citalopram or Celexa, was used as a level 1, adequate level for adequate length of time. So everybody in the trial, 4,000 patients, were on that first. Average dose was about 35 milligrams. Those of us who are prescribers know that's on the higher dose of normal. So it's approved from 20 to 60 milligrams. Subsequently, it was changed to 20 to 40. But anyway, this is not a pharmacology presentation, but gives you an idea. Those who did not respond adequately to citalopram could be switched to sertraline, bupropion, venlafaxine. Those who had partial benefit can have an add-on of a different mechanism, bupropion, Wellbutrin, or buspirone. Level 3 intervention was those who did not respond to level 1 or 2. Mirtazapine, which is an atypical antidepressant that's known as Remeron, or nortriptyline, which is tricyclic, or you can have the option of adding on augmentation with lithium T3. And similarly, so level 4, anybody who did not respond to the first 3 levels had an option of MAOIs. Monoamine oxidase inhibitors are rarely used today, not because they're not effective, they're very effective, but because there are so many restrictions with diet with them. Or a combination that some of you know, Dr. Stephen Stoll from San Diego, he calls it the California super duper combination of venlafaxine and mirtazapine, which is a combination medication. Let's go back to the previous slide. Yeah. So this slide shows you the outcome with the STAR-D. So you notice that those on level 1 had a good response, but only about 1/3 of them had remission, and they were measured by symptom improvement scales. Then level 2, you have declining returns, as you can see. And you also had, which we don't have a slide for that, but increasing dropouts with medications because of tolerability issues and polypharmacy. Next slide. So how does TMS work? So the timing was perfect because TMS was introduced and was FDA approved in 2008. Actually, on a side note, I became familiar with TMS in 2000. So that's even before FDA approval, because I practiced in the Stanford area and finished my residency at Stanford. And Stanford was one of the sites of the trial. There were 23 sites in North America that TMS was studied in. Stanford was one of them. And my specialty has always been treatment-resistant depression, mood disorders. So one of my private patients, at that time, she was 22 years old, Stanford student, actually, who we tried everything for 2 years, psychotherapy-wise and medication-wise, nothing was working. So one day she walks into my office and says, I want to do TMS. She had found out that Stanford was doing the trial. So long story short, in 6 weeks, she was a new person. I was so impressed. That's when I became a believer in the year 2000. It took 8 more years of studies before it was FDA approved. And I jumped at it and I started Silicon Valley TMS in 2010. So the science behind TMS, magnetic field generation. So the whole idea, you see this magnet on the right, this is this device we have, the NeuroStar magnet, is placed on the prefrontal cortex and you stimulate it. The protocol used to be 37 minutes or so. Now it's 19 minutes. It's been high power coil. Now we use that, which is very well tolerated. And you tap on the brain with this high power magnet, and it's a non-invasive penetration. No surgery, no anesthesia, no pain, essentially. Well, I shouldn't say no pain, minimum pain. That's really the main side effect in about 10-15% of patients, but nothing really severe. And it penetrates the skull and the scalp area 2 to 3 centimeters and stimulates the area underneath the coil. And it generates, the theory behind it generates microelectrical circuits in the brain that improve connectivity and neuronal activation. So neurons are electrochemical areas, induced areas are localized. TMS can both excite and inhibit. So that's an important sentence here. The protocol for depression is what's called high frequency protocol, which is 10 hertz. That's an excitatory. But there are some experimental protocols which are called low frequency, which inhibit areas of the brain. But that's FYI for information only at this point. The entire process is non-invasive and does not require any breaks in the skull or brain issue. And patients come in on their lunch break and then leave. There's no restriction on driving. Next slide. This is a good picture to show you the patient in a treatment position. This is the coil. This is the control panel. And she looks happy and relaxed. And basically, you target the left dorsolateral, regardless whether you're right-handed, left-handed, the left dorsolateral prefrontal cortex is the target. And I mentioned high frequency, that's 10 hertz. Why the left dorsolateral prefrontal cortex? That's considered the central hub that connects mood areas of the brain, what's called the limbic system. So what it does, it depolarizes neurons, activation of networks, And because of connectivity with the billions of neurons, the deeper areas are stimulated through connectivity in the brain. So the areas are impacted directly are the dorsolateral prefrontal cortex. But because of the connection with the anterior cingulate, if you remember on my earlier slide, the limbic system is the whole mood area of the brain, including the amygdala, and then there is the subgenual cingulate gyrus. There was an experimental treatment called deep brain stimulation, which never really got FDA approval for depression. That's used for tremor in Parkinson, but that targets the subgenual cingulate gyrus. Next slide. So this is really the exciting news. The exciting news is that we have great success with TMS. As you can see, this is the slide provided by the company that makes Neurostar, which is the system we use. I mean, where can you see 83% improvement in depression symptoms and 62% remission rate? If you look at the most ambitious pharmacology studies, you're looking at 30 to 40% if you're lucky. And I showed you the Star D trial at the end of the trial. And by the way, I didn't mention that each step was at least 2 months. So you're looking at 8 months out, people are still, you know, a significant percentage of them are still symptomatic. Those who did respond are still, some of them are impacted by side effects of the medications. So that's why I'm excited and continue to believe in TMS, and hopefully you believe in it also. Next slide. So this is actually a summary of the tolerability issue. If you look at the right side of the slide, I mentioned earlier the main side effect of TMS is some people have scalp pain or discomfort, but we've modified the technique where we start with a lower percentage and proceed up. Rarely people need some pain, over-the-counter pain medication in the first or second treatment, and Tylenol or Advil, Motrin can take care of that if needed. The majority tolerated with no problems. So TMS has fewer side effects. Again, not to belabor the issue, I think we talked about medication side effects on the left side. Next slide. So what's the evidence? Where is the meat? What's the evidence base? So it was approved in 2008. In 2010, by the way, coincidentally, that's the month I started Silicon Valley TMS. This was published, this statement by the American Psychiatric Association was coincidentally published the same month we started Silicon Valley TMS. And it said that's the first time TMS was included in the general treatment guidelines, what's called best guidelines for depression. Acute phase treatment may include medication, depression-focused psychotherapy, combination of medication and psychotherapy, other somatic therapies as ECT and TMS or light therapy. We presented our data in 2013 to the APA and it showed significant improvement. Of course, there are millions more patient treatments since that time in the past 12 years or so. It's a valid alternative to somatic therapies like ECT. You know, it's non-invasive, no side effect. ECT is effective, but it has a lot of cognitive side effects and recurrence rates are very high. Sometimes we use TMS as an adjunctive with other approaches, including psychotherapies. And that's the nice thing about TMS, come as you are. Patients can be on medication if they're having a partial benefit, or they might have a therapist that's doing well with them, but they're still having. What I didn't mention is we also do measurement-based assessment. PHQ-9, Burns depression inventory, Hamilton depression, etc. So we measure depression, and a lot of the people who are better are not well. So for example, if you're familiar with the PHQ-9, so under 5 or 6 is considered no depression. And then a lot of my, prior to TMS, a lot of my patients were hovering in the low teens, you know, like 13, 14. So they're not 27 as they were when they entered my practice, but they're not completely well either. So those may be good candidates for TMS. So I encourage all clinicians to actually measure their patient's depression, and PHQ-9 is a good, easy tool all of you are familiar with. And if the PHQ-9 is not comfortable, or particularly mid-teens onwards and higher, I would definitely refer them for a consultation for TMS. It could be used as an adjunct to medication also. Thank you. Next slide. Thank you, Jordan. So basically, best practices. This is actually a slide provided by Neurostar. It's actually maybe redundant from what I showed earlier. First-line treatment. If you have a failure in first-line treatment, there's no reason why you can't go to TMS right from the beginning if you wish. But most insurances require you to at least try 1 or 2 medications if you're going to go through insurance. So if you don't have TMS, you can do antidepressant switch, augmentation, atypicals. We touched on that with the STAR-D trial. Those who need a higher level of care can benefit from intensive outpatient, partial hospital, ECT, DNS. I'd mentioned DBS. DBS is really, that slide needs to be changed because it's not really evidence-based at this point. The studies were disappointing with it for depression. It's a good treatment for Parkinson tremor and essential tremor. It involves ultrasonic surgery under fluoroscopy, but it is invasive. Next slide. So advantages of TMS: it's safe, non-invasive, good tolerability. It's FDA cleared for major depression with or without anxiety, OCD, and smoking cessation. It's reliable and consistent results. Sorry about the overlap here on the slide. Oh, you have it with, in mine it's overlap. So reliable and consistent results. It's considered innovative treatment. It gives great, I can tell you lots of stories based on my 7,000 patients of how life-changing it has been to have TMS part of the treatment. Either monotherapy treatment, I'd say about 1/3 of the patients we treated have not tolerated any antidepressants, and they come just for TMS. The other 2/3 are on medication. Half of those will be on less medication at the end of the treatment. So, and some of them can be off medications eventually. So it gives you a good idea, and you can use it as complementary. I think I am ready to get my brain neuroplastic by your questions. So I'm going to open it up. So thank you for your attention. I'm going to open it up for questions soon. And thank you for attending. And Jordan will be handling the questions, and I'm happy to answer them.
Thank you so much, Dr. Shakir. I'm looking at our chat, and I'm not seeing questions in yet. Lauren, are you seeing them in your end? And if not, if those who are on have not yet typed in, now is the time. Definitely can pick the brain of a renowned psychiatrist and leader in the field of TMS.
I'm not seeing questions. Oh, yeah, we do. That was a question. Go ahead, Linda.
Hi, sorry. I have a 6-month-old on my lap who is going crazy. Well, let me see. I'll share my camera. You can see a face. Allow. Is it coming on? There we go. Hi.
Yeah.
It's cute.
Did you say 6 months?
Yes.
Wow, looks like a mature baby here.
Yeah, he's very, he was born with a full set of hair, and we had to cut it twice already. So my name is Linda. I'm a licensed clinical social worker. I work with primarily chronic pain patients with fibromyalgia, migraines, things like POTS, CRPS, complex regional pain syndrome, nerve pain, lots of pain. And oftentimes what we use is the latest is pain reprocessing therapy and acceptance and commitment therapy, some IFS, changing their relationship with their pain to feel safe with their body again. Essentially, I tell them we're developing a new neural pathway of feeling safe with the pain, and symptoms go down. Though barriers include OCD, trauma. It's very difficult for their brain to rewire to feel safe again. And I love the review of the brain, and I noticed towards the end you focused on depression and PHQ-9. I'm wondering, do you provide the tier 3 for OCD or chronic pain? And by the way, I'm in Orange County, and a lot of my clients are from LA, Orange County. So I'm wondering if you provide for OCD and chronic pain.
Great. Well, I'm so glad you asked the question. Do you want me to jump in, Jordan? Yeah.
Yes, please.
I'm glad you answered the question because we have a lot of experience, what's called off-label uses. The main downside, well, I urge you when you work with pain patients, actually at Silicon Valley TMS, we had 6 clinics. One of them was in Santa Cruz, California. And my partner there was a pain management doctor. And she saw a lot of pain patients. So we treated a lot of pain patients. So I urge you to do PHQ-9 on them. I'd say in our experience, over 70% of them, their PHQ-9 was high. And why is that significant? I mean, we treat them even without PHQ-9 being high, but that's significant if they have insurance. Because if they have insurance and they meet the criteria, and then PHQ-9 is 15 or higher, basically we treat the area of depression. That's the prefrontal cortex. And then we've had significant improvement of the pain. However, so there is research now in treating the motor cortex. So that's off-label. We treat the prefrontal area. So the area we treat is 6 centimeters in front of the motor cortex. But some of the studies have been focusing stimulation on the motor cortex. Like if you have limb pain, basically identifying the area in the brain that controls that limb and stimulating it directly. However, that's called off-label treatment. So what we've done in some cases, if they don't respond, if they meet criteria for depression and we use the standard protocol, they're happy because the insurance is covered. In many cases, the pain is improved. If they have residual pain, we could then go off-label and treat the motor cortex area. In that case, obviously, it will not meet the insurance criteria. But yes, we've had some good success with pain management. Now, fibromyalgia is a different story.
Yeah, I often do my work based on oversensitization, central sensitization pain. So my work is more on targeting the limbic system, the nervous system, the amygdala, the emotional brain. So I tell folks I can't target your nerve responses, but I can target the layer that's oversensitized because of trauma. So I guess I'm trying to understand, how can I present TMS to my patients who have worked long-term, not long-term, but on working on the amygdala and central sensitization pain. How is targeting the frontal lobe? How would I present that to patients? Like the transition of treatment, because I can hear them say, well, you're telling me I should focus on my amygdala and nervous system. How is TMS targeting the frontal lobe supposed to help me?
Yeah, I think, let me answer that specifically and then expand on the question. So specifically, the brain is highly wired that when we treat the prefrontal area, I have many slides that show you a crescendo effect on deeper parts of the brain that regulate pain, etc. So you can tell them the brain is highly wired. This is as I mentioned, I use the term, the central core of the limbic system is the dorsolateral prefrontal cortex. You can use my term, I call it Grand Central Station. So that's Grand Central Station. So in terms of getting them on board, that's a good approach. Obviously, you can elaborate on it, etc. But what I will expand on is how I learned about fibromyalgia. Remember, I've been doing this for 15 years. One of my early depression patients was a nurse who's married to a physician in our local area. And she had refractory depression and many other trauma issues, etc. So our goal was to get her depression improved. She's had severe disabling fibromyalgia also. So at that time, I didn't know that worked for fibromyalgia. So after an acute course of treatment, her depression was gone. And one day she comes in with her husband, who's a physician, and says, what did you do to me, Dr. Shakir? I don't have pain, fibromyalgia anymore. I feel it, but it doesn't really bother me. And she continued to be pain-free for many years that I followed her, because the area with fibromyalgia is very closely connected to the dorsolateral prefrontal cortex. So connectivity is really important. That compared to more localized pain, I can tell you another story of a young woman who had amputation related to a car accident. and she had phantom pain in the area that was amputated. So in her case, we treated the area of the brain that represents the phantom limb that she lost, and the pain was gone. So we treated that specific area. So that's the off-label treatment. Fibromyalgia, oftentimes they have depression and they meet criteria. So I'd be very happy to treat those patients because we get some really excellent results.
So the device, sorry for interrupting, the device is on the frontal lobe. So you're saying we target the part of the phantom limb pain. You can adjust where it hits.
Yes. Yeah, the phantom leg pain, we go to the motor cortex.
Okay.
So that's actually the prefrontal area. If you're looking at my picture, is here. The motor cortex is around here. Yes. So we go to the motor cortex. In her case, I think she had right limb amputation. So we did left side stimulation of the motor cortex where the phantom leg was.
Yes.
And the pain disappeared.
You know, this is making sense. I often talk about the states of the nervous system. And when I talk about shutdown, the depression, dissociation, low mood. Yeah. Okay, that's so helpful. I believe in TMS and for definitely depression studies. Chronic pain, I haven't heard so much, but I can see how targeting the depression.
So let me give you a name of a person who does a lot of research. He's in San Diego, Dr. Albert Lueng, Lueng. And you can look into some of his research. I've heard him present in some international meetings. He's an authority on TMS for pain. So Dr. Lueng. It's really an very exciting field because, as you know, these people are highly disabled. And what you do with them is wonderful. So consider TMS complementary to the great work you're doing with them.
Dr. Lueng, Albert, okay. Are they from UC San Diego Hospital?
I think so.
Yeah, I think I got a referral from Lueng. That's so funny. From UC San Diego and pain management. Yeah.
So where are you located? Orange County, you said?
Yeah, I'm in Huntington Beach, but I provide California services.
Come and visit us, huh, Jordan? Let's invite her to come to us.
I work for a chronic pain company right now, but I'm going back into private practice soon. So that's why I'm here. I'm learning. I'm getting the resources. I took time off for my baby from private practice, but I'm coming back soon. So I'm getting.
Well, we look forward to collaborating with you and make sure you come and visit us.
Yes. Thank you for answering my question.
For the questions. Great question.
So wonderful. I see we have another question in the chat from Andy. It says, I wonder, what are the requirements to clear with insurance provides to receive TMS? What does the cost look like paying out of pocket? Also, what's the estimated treatment duration? So a lot of the logistical.
Okay, so let me start, and then maybe you and Brad can discuss the cost issue and the discounts you may offer. But let me discuss the criteria. So the good news here, so it's been FDA approved since 2008. Initially, when it got approved, so when we started, there was no insurance coverage. So basically everybody, and Silicon Valley is a wealthy area, as you all know. So we had no problem recruiting patients who private paid for the treatment. At that time, it was in the 10, 12,000 range for the whole course of the treatment. But in 2013, insurance came to us, actually. The biggest two insurances, I don't want to mention names here, but one is an HMO, one is a PPO. They came to Silicon Valley TMS and says, hey, you are having great results. Can we contract with you? And the rest is history. Now, most insurances do cover TMS. So the good news, not to make the story too long, is initially the bar for approval was very high. It used to be like 4 different medication failures, psychotherapy failure. But with experience and success with TMS, the bar has come down. Most insurances, and Lauren will probably add because she has a list of the requirements of different insurances, but most of them 1 to 2 medication failure in this episode qualifies them. Lauren, do you want to jump in and add your piece? This is Lauren.
I absolutely can. So yes, it depends on the insurance. We are currently in network with Aetna and United Healthcare. We are waiting on our finalization of contracts with Cigna, Evernorth, Kaiser Permanente Southern California, Blue Shield of California, and Anthem Blue Cross of California. I think that covers all of them. Our accelerated TMS package, which is a 5-day protocol, is priced at $10,000. Our standard 36-session treatment protocol is priced at $12,000. We do accept care credit, and we offer sliding scale pricing for those who do not have insurance that we are in network with. Feel free to contact our office to discuss pricing.